Today we're going to be talking about artificial intelligence and rheumatology. I'm Mel Speisman, president of American College of Artificial Intelligence and Medicine. Just a few days ago, I did a PubMed search to look at the medical literature on this topic. And if you type in quotes, artificial intelligence and rheumatology, there are over 1,000 articles on this topic. Now, that may seem like a lot to you, but it really is not. To give you some perspective, in cardiology, in a year's time, 1 year's time, there might be 2,000 papers or more. In pulmonary critical care, the same. So this is a relatively small number compared to a lot of the other specialties. The reason I'm telling you this is we're only beginning to explore how to use artificial intelligence in rheumatology. It's been very well worked out in radiology and cardiology, but it really is at the beginning phases in rheumatology, and it's super exciting. A lot of the things I'm going to show you are published days to weeks ago. That's how cutting edge this is right now. It's truly going to transform how we take care of a patient with a rheumatic disease. So we're going to just start with some examples of how can we use AI for autoimmune diseases. What a large language model can really be good at is if you enter some symptoms that a patient is complaining of that are just very obscure, that don't seem to fit a typical pattern. It's really good at recognizing rare diseases, maybe diseases that you've never heard of. So aside from that piece, which you see in the second box, there's been a recent validation study that found that large language models have a very high diagnostic accuracy in inflammatory rheumatic diseases, identifying a high proportion of cases correctly compared with an expert physician, like a rheumatologist that is in practice for many years. It's as good at this point. Another way you could use AI is to generate some information to hand to the patient about, let's say they had lupus, and you tell AI, well, write some information for my patient who's in the office with me to explain in layman's terms about lupus. Now, what's really interesting and cool is we are still doing better than AI at this piece. There's been some recent studies showing that the American College of Rheumatology patient handout information was better than what ChatGPT generated. So, always hear about how AI is doing better than physicians, but in this example, we as physicians are still doing better than AI. So I thought I'd share that with you. That kind of is nice to see that we could still perform well. Other examples of how we might use artificial intelligence in rheumatology. This notion of getting prior approval. So my program director, when I was a resident, was a rheumatologist here in Chicago. And we would frequently go and rotate with him in his office or just come to talk with him. And the biggest challenge that we could see when we spent time with him was getting the prior authorization to give a patient, say, a tumor necrosis factor type of drug for autoimmune diseases. And so you probably, hopefully, are aware that for these very difficult, burdensome tasks, like writing a letter for prior authorization, AI is really good at that now, and so that's like an easy win for you in terms of using it as a tool to reduce the burden of administrative work, so to speak. And this could really help a patient because, there could be delays in getting this really important medicine if you don't jump through all the hoops that are required to get it. So we're just going to start with a few overview concepts, and then we're going to go real specific. And this is going to be a case-based discussion where almost every example I'm going to give you will start with a real patient and then look at how we can use AI very specifically in that case today. This was a nice review, though, on advancing artificial intelligence in rheumatology with evidence. If you know me well, you know I teach evidence-based medicine. That's what this lecture is going to reflect. So some things from this paper that just examples that I think are really good. The first is that there are over 1,000 FDA as AI as medical device algorithms that are approved that we can use today. But 75% are in radiology, 10% are in cardiology, but there are none right now in rheumatology. But that will change as this year progresses. An example where typically, often Europe is sometimes ahead of us in approval for things. They use the EU certification, which is called the CE mark. And there is actually one example here called the ROPCA platform that is CE certified and can be used in Europe. And it's an ultrasound scanner that has AI embedded in it that will allow you to look at hand joint synovitis. For example, diagnosing RA by doing an ultrasound of the hand. Now, what I've learned, because I've spoken to some rheumatology fellowship programs in this talk, this is very common now that people who are, say, some of the program directors of fellowships in rheumatology are teaching their fellows how to do ultrasound of the hand to look for synovitis, just like you do POCUS here in the hospital, for example. So our organization has an AI and rheumatology lab group that is about to start a project looking at AI and ultrasound for our RA. And some of the chief residents that are in the Chicago area that are interested in rheumatology, and then some of the university programs here and elsewhere are going to collaborate with us on this project. So if anyone's interested in doing a rheumatology project, you could shoot us an email and then be part of this paper we're doing. It's in its beginning. The project is just starting, so let me know if you're interested. But back to examples. In rheumatoid arthritis, machine learning models can help us know whether giving a patient methotrexate is going to be effective, and that's like precision medicine. Like some patients respond better to certain drugs than others. In ankylosing spondylitis, AI can read the MRI image or the CT scan so that we have a quicker time to diagnosis. In psoriatic arthritis, AI can look at the medical record, the EMR, like Epic, and look for subtle clues to the fact that maybe someone has psoriatic arthritis, recognizing it before maybe we do. So these examples, if we did them all together, we call that multimodal. Like if AI can look at the medical record and look at the X-ray images, that's called multimodal. That is what you're going to see when you look at papers coming out in 2026 about AI for medicine. You're going to start to see multimodal. That's not the norm yet, but that's where we're headed. And so that's closer to the way we think as a physician. We take a history, we examine the patient, we look at their x-rays, their labs, we try to put it all together. That's what multimodal is going to be in AI, putting it all together, looking at all of that, and then saying what the diagnosis is and what the treatment should be. So what I can tell you is that in all the different specialties of medicine, the very first way we try to just get our feet wet and get started in any specialty with AI is just to feed the AI some multiple choice questions before we even start using it in the real world setting. So this was a really nice paper that compared different large language models feeding it multiple choice questions in rheumatology, like the MixApp, for example. Now, why this is really important isn't so much that multiple choice questions. The original studies on this, just in medicine in general, when they did it at first, when large language models came out, it only got about 40% of multiple choice questions right, which is not good at all, right? And then about a year later, after training the large language models over time, they learn and get better. It went from 40%, which is not good, to 80%, to now better than any of us in the room will be able to do on multiple choice questions. Well, why I'm highlighting this paper is you probably know that we have many choices that we can use for large language models. Like you could ask the question or put the information into ChatGPT, but you could also, there's many other companies that have large language models. For example, another one is called Claude by Anthropic, or Google. When you go on Google now, and right next to Google, it says you want to use AI, that's called Gemini. They don't really announce it so much, but that you're using Gemini. So they compared these different models, and what they found was important because you have choices and you want to pick the tool that's going to lead to the best results. So in the case of rheumatology, the highest accuracy was actually DeepSeek, followed by Claude, ChatGPT 3 and 4, and Gemini, and Open Evidence. So in this example, you could see they were all pretty good, but they weren't equally good. And we will look at some other studies here that find not necessarily what we saw there. So by the time we're done with this talk, you'll have a sense of which large language models are performing better in the medical fields, specifically in rheumatology. So this is a really good one from May of 2025. And what you can see on the boxes here is that for large language models in rheumatology, ChatGPT had the highest diagnostic accuracy, followed by Claude, followed by Copilot, followed by Gemini. So if you had to guess which one I'm using all day, every day, for sure I'm using the one that's performing better than the rest. So I'm going to just give you the data and you make your own decisions as to what you want to do. So let's jump into the cases. I have a lot of cool cases in rheumatology to show you today. This 23-year-old woman had joint pain, morning stiffness, and a facial rash, and you ordered the ANA. So the question is, how could AI be helpful? So in this study, which was published in February of 2026, which is not too long ago, it's right now, it came out, they found that AI could be helpful in interpreting the ANA results and being definitive as to what autoimmune disease it is, and was more accurate and much faster than a clinician. So that would be a good use of AI in rheumatology. A 37-year-old woman comes with a 6-week history of pain in both her hands and morning stiffness. She has swelling and tenderness of both hands at the MCP joints. How would you use AI in the primary care setting to confirm the diagnosis while you're waiting for her to see the rheumatologist? So what's very common is these patients don't go to the rheumatologist. They come to you in your clinic, and you're trying to decide what the diagnosis is. Maybe you're not sure. Can AI help you while you're waiting, several weeks or months to get into rheumatology? So in this paper from January 12th of 2026, which is just recently, a few weeks ago, they were able to use machine learning to help us in the primary care setting identify rheumatoid arthritis. And they tested 5 machine learning models, and the one that performed the best was called Cat Boost. And the area under the curve was 0.966, which is almost 100%. So I mentioned the ultrasound study. This is the article that shows the ultrasound study for RA and using AI. So we can do that. But also we can use it to decide on treatment. So machine learning can predict a patient's response to different drugs in rheumatoid arthritis. So this was a nice review of all the studies showing how machine learning can predict which patients will respond to which drugs. So there were 6 different machine learning tools that were used. The one that worked the best is called extreme gradient boosting. So what we found in our work at the college is that the type of machine learning model that seems to always outperform everything most of the time, not all the time, is called gradient boosting. So you're going to see that come up again in all these papers that are coming out now about AI and rheumatology. But in the real world, you can then use this to determine whether to give a patient methotrexate or not as their therapy. So this was another paper. This was from July 2025, showing that the machine learning approach was able to predict which patients would go into remission with disease-modifying therapy, allowing for what we refer to as precision medicine or personalized care. So let's say we started them on a disease-modifying agent, which for sure we're going to do. How could AI help us know whether by the time we see them again in 4 weeks, they're going to have a flare or not on their current therapy? So I really like this one. So when I spoke to you about cardiology, we mentioned that the Apple Watch can detect atrial fibrillation. And then when I spoke about pulmonary, I told you the Apple Watch can detect sleep apnea. More recently, the latest app for the Apple Watch in healthcare, it can detect hypertension. So these are like what we do every day on our patients all the time, right? We have so many patients with hypertension or atrial fibrillation or sleep apnea. These are like the core of our internal medicine patient care. But this is really interesting. We can use that same concept of the wearable watch or a wearable, I'll give you some other examples, to predict whether someone is going to flare before they see you again and then intervene now so that they don't flare. Think how amazing that is. Instead of seeing them in a month and they're like, oh, I'm all flared up, you could just, if they're wearing a watch, a smart watch, we can figure this out before it even happens and then take action to intervene. Like, this is amazing. This is where medicine is going in your near future as a practicing physician. It's super exciting. So let's look at this one. This was a wearable for rheumatoid arthritis. And it wasn't just the Apple Watch. You could do this with a Fitbit. When the Fitbit came out, we purchased a Fitbit. Everybody was wearing it. It was ridiculous. Everyone and every doctor in the hospital had a Fitbit. And then these other things came out and everyone put their Fitbit in the drawer. But in this study, Fitbit worked, Apple Watch worked, or if you don't want to do that, there's a ring that you've heard me talk about called the Aura Ring. Regardless, data on heart rate. And so those of you that are really interested in cardiology or heart rate, even if it's not specifically relating to cardiology, is a very powerful tool in detecting flares of disease. So in this case, heart rate was higher in symptomatic periods. Not only the mean heart rate, but the daytime heart rate, the nighttime heart rate. You can look at the different patterns of the heart rate. But the bottom line is that you could predict if someone was going to flare because you could detect it on the heart rate variability before they had symptoms and before you could see it when you examined them or before they could complain about it. Weeks before you could detect this for rheumatoid arthritis. And if you probably don't recall, but when I spoke to you about gastroenterology, an inflammatory bowel disease, which is kind of an autoimmune disease, like the rheumatological disease, the same thing, we found a smartwatch through heart rate could detect a flare before the patient even had symptoms. So I think this is really powerful in terms of us intervening before someone complains to you of something and being a real difference maker in the care. So this is actually a true, another case. This is a true in the sense that it's a personal for us. My wife, Ann, is executive vice president of this organization. We've been practicing together as hospitalists in teaching residents and students for a long time. But this actually happened. It was, my wife was having Thanksgiving dinner with the family, and she was sitting across from her sister-in-law. And she looked at her hands, and they were very tight. Now, she had no medical problems at the time. Then she looked at her face and noticed that there were telangiectasias, and talked to her and found out that even when she went out in the cold, that her hands had some signs of Raynaud's. So Anne gave her sister-in-law a prescription for blood tests for scleroderma. The titers were high. We sent her to see our mentor, who's a rheumatologist. But why I'm telling you the story is AI can be used in systemic sclerosis in a variety of ways. But one is, I'm sure you know that you can look at the nail fold of someone with scleroderma and see abnormalities that are consistent with scleroderma. Now, this is something rheumatologists learn to do. And there's actually a simple tool, a dermatoscope. It just magnifies the nail bed that you could put on their finger. But AI can then, because this is an image now, AI can be attached to that scope with your smartphone, look at the image and detect whether or not there's scleroderma on a nail bed. Can you imagine? Let's say you didn't know yet the patient had scleroderma, but you could just take your phone and attach it to this magnifying dermatoscope, put it on someone's finger, and it could just tell you in an instant, patient has scleroderma. Can you imagine? They haven't been diagnosed yet. The blood is just in the lab. It hasn't even been run yet. And you could know with a really, literally 100% certainty in the office. Like, think about how amazing this is. And this isn't theoretical. You could do this right now for real. So in this study, which was published in November of 2025, just a few months ago, they did deep learning, and they got an area under the curve that ranged from 98% to 100% performance on this, what's called nail fold video capillaroscopy. So we talked about the nails in systemic sclerosis, but our sister-in-law and most people eventually over time get lung involvement. And so AI is really good at reading x-rays, CAT scans, and it can detect the interstitial lung disease associated with scleroderma. It's been many studies showing this, but this is just one of many from October of 2024. Another case, a 28-year-old man has low back pain. examination of his lumbar spine. You have him lean forward. You find that range is limited. You do x-rays of the lumbar spine. But how can AI help? AI, again, is going to be really good at looking at or interpreting x-rays, even better than a radiologist. So this was a machine learning study for spinal arthritis using random forest. And then I have another study. This was for ankylosing spondylitis. That was from December of 2025, just a couple of months ago, using AI to look at the x-ray of someone and read it. And so I want to show you, like, specifically how this looks. So you can, the zeros, the ones, the twos, the three, that's how much spondylitis there is. So it's showing you each of the cervical vertebrae here and whether there's spondylitis. And this is AI reading it. So just amazing. So there's many, many papers now on AI reading images for spondyloarthritis. So just be aware, it's just well established now. It's been worked out. And all of this is very recent, just in the last year or so. This is a paper on AI for reading images in rheumatology in general, which is what we're talking about. This was from August of last year, so about a half a year ago. Algorithmic approach to hand imaging for rheumatic musculoskeletal diseases. So they looked at 400 different studies that have been published. So AI has been studied very extensively for RA of the hand, but also OA, psoriatic arthritis. And if you recall, when we talked at the beginning of these series of lectures on pulmonary or the imaging of x-rays, the type of AI that we use to read that is called a convolutional neural network. So that's typically what is done to read, say, x-rays of the hand to look for RAOA. Now, what about encephalitis? Well, I mentioned at the beginning, why you need to know the subtleties here is we have choices of which large language model we might use to look something up. We have choices about which type of machine learning algorithm we might use to help us diagnose a patient. So in this example, they compare two different models. One is called Rapid, one is called Optimize. They did a head-to-head comparison. And they found, these are deep learning models, that the C-Optimize had a 90% sensitivity compared to the Rapid, which had an 82%. So again, my point is, I'm going to teach you some of the literature, the evidence, and I'm hoping you pick the models or the tools that have the highest performance. More on just imaging and rheumatology. This is a paper from April of 2025, AI for the evaluation in rheumatology using computer vision. So RA, spinal arthropathy, systemic sclerosis, even giant cell arteritis have a really high sensitivity specificity using computer vision. So back to cases, because I like to teach with real case examples. This is a 56-year-old woman that has pain and swelling in her hands and feet and knees associated with stiffness of the joints in the morning. On exam, there's tenderness and swelling in the PIP and DIP. Now, this part is critical. You look at her scalp and there's a little plaque there. What machine learning model will predict a flare 3 months before you see the patient again in clinic? So this is obviously psoriatic arthritis. There are explainable machine learning models. I mentioned it's called gradient boosting that works the best. It could predict a flare 3 months before you see the patient in clinic. So that gives you a chance to alter their treatment to try to control it better. So this paper was in the Journal of Rheumatology, January 2026, so just a month ago. Actually, only a couple weeks ago, January 15th. Predicting treatment outcomes in patients with psoriatic arthritis or spondyloarthropathies with AI. Machine learning models could predict low disease activity, high disease activity in patients with psoriatic arthritis, ankylosing spondylitis, and how they're going to respond to the drug that we give for that called secukinumab. Another example with psoriasis or psoriatic arthritis from April of last year. This was looking at nail images. So in this case, they trained the model on nail images, 4,400 nail images of patients with psoriasis. And now the CNN could look at someone's nail and predict or determine that that's the diagnosis. So moving on to a different disease in a different case, this is a 32-year-old man with oral ulcers and genital ulcers that's having a flare. What machine learning tools can be used to diagnose Behçet's, right? You're going to probably see this on your board exam. Enhancing the diagnosis of Behçet's. So we can use random forest and we can get an accuracy of 96.7%. Or XGBoost, 0.9985, even better, right? So machine learning very good at helping diagnose Behçet's. But this is an even deeper level here. In September of last year, if you remember my oncology talk, we talked about proteomics, genomics, metabolomics, transcriptomics. These are all new terms for using AI to analyze data. In this example for Behçet's, proteomic data was used in an XGBoost model to help diagnose patients with Behçet's, and the accuracy was 0.935. So precision medicine, it could be in oncology, it could be in rheumatology, it could be for diagnosis, it could be for what drug to use, it could be, will someone respond to the drug? Will they flare even before you see them again? So very similar, whether we're talking about cancer care or rheumatology. 29-year-old man with fever, abdominal pain, arthritis, and a rash. This is a common board type question. Fever, abdominal pain, arthritis, and a rash. Anybody have a thought on what this is? Anybody? He's had an episodic attack similar to this one in the past year in his grandparents. It's familial, right? Now, that question is, which large language model would have the highest accuracy at diagnosing this? So this is FMF, right? They did a head-to-head comparison of two large language models, ChatGPT or Llama, to see which would be better at diagnosing familial Mediterranean fever. Not surprisingly, because there's a trend in all these studies, Llama accuracy was only 51%, ChatGPT 80%. Also noteworthy is 9.7% of the time Llama responses were contradictory to guidelines, whereas ChatGPT was never contradictory to guidelines. So it matters which large language model you use out on the floors or in the clinic or wherever you're using them. So just be aware of the evidence. 65-year-old man is hospitalized for acute heart failure. We see this almost every day. You give IV furosemide, and now they complain of pain in their ankle or their knee. But how could AI help us in this case? So gout is very common after giving IV furosemide to people who have heart failure and gout. You trigger a flare. So if we could predict this in advance, we could perhaps do something to prevent this from happening. And so that's what this study was looking at. Again, a machine learning model that predicted patients that would be at high risk for having a flare of gout. So the next one, a 67-year-old woman, bilateral headache, pain in the jaw. How can AI be helpful in diagnosing giant cell arteritis? And now we're back to the ultrasound imaging. So in this study, they used the handheld ultrasound to help diagnose giant cell arteritis. So This was from Annals of Rheumatology in September. So, we could, wait for the biopsy and confirm the diagnosis, but you can have an answer like right there at the bedside if you put the ultrasound on their temporal artery and you have AI enabled into that. So just think of how amazing that is. You could literally prevent someone from going blind and know the answer immediately. Now, just as we kind of coming towards a close to the talk, and then I'll open it for questions. You guys probably know that I'm extremely interested in cardiology, and patients with autoimmune diseases tend to get cardiovascular disease at a very young age, and it often doesn't get recognized or assessed. So in this study, they detected coronary artery disease calcium in patients with autoimmune diseases. And they found that in autoimmune diseases, the incidence of coronary artery calcium was extremely high. And it was associated with all-cause mortality and MACE. So where I'm going with this is you can use AI to look at CAT scans that were done for other reasons, and we call this opportunistically detect coronary calcium. So you were not sending them for a coronary calcium scan. They had scans for part of their workup of autoimmune disease because it's, systemic illnesses. It's going to affect all their organs. They're likely to get CAT scan. You can have AI go back retrospectively and see if there was coronary calcium. And given that these patients get it at a very young age, and it's one of the main causes of mortality, imagine how we can use this then early on to start them on statins and aspirin and try to prevent what's really going to be their demise. So this is kind of going to be the close, the last two slides, and then we'll see if anyone wants to fire a few questions. But this is just, the next two slides are a really nice table that I wanted to share with you that gives you the name of the AI tool, and then at the other side of the slide tells you with the exact reference how it was used to treat a specific disease. So let's take a look at this. So logistic regression, it says that uses a logistic function to model binary dependent variables. So how has this been used in studies for rheumatology? Well, it's been used to predict the relapse of RA, to diagnose ankylosing spondyloarthropathies, to diagnose autoimmune diseases, to predict who's going to be hospitalized if they have lupus, and to predict mortality for systemic sclerosis. The next AI model is called linear regression. That is been used to predict response to methotrexate, which we talked about, or response to the other disease-modifying agents, the newer drugs. So like the TNF drugs, the MABs. What about support vector machines? These are some studies where that was used. So fatigue prediction in RA through brain MRI, prediction of complications during pregnancy in lupus patients. Decision trees used to diagnose and predict RA, predict response to disease-modifying agents or complications in pregnancy. Random forest, a commonly used machine learning model predicting responses to disease-modifying agents. Hospital admissions, mortality. So again, when we do head-to-head comparisons of these different tools, the one that has the highest results is the XGBoost. So these are all different machine learning models. Most of these studies do head-to-head comparisons. Almost always XGBoost is the better way or tool to use to predict relapses in RA or decide on disease-modifying therapies. Convolutional neural networks, we mentioned, that reads the X-rays. Okay, so the last thing, the transformer, is the large language model. That's like the ChatGPT or other examples. And that primarily looks at words, like your EMR notes, for example. to help you find things. So I'm going to open it up for questions, but this is really cutting edge stuff. If I was talking to you a year ago, most of this didn't even come out yet. So this is where medicine is heading. And even though this is rheumatology, you're going to see the same thing in all the fields of medicine. This is what medicine is turning into. And it's like amazing what we will be able to do just in the next few months or years. So, but just anyone want to fire out any kind of question?
So basically, all those language models, so are they going to be integrated with our electronic medical records?
You know, this is an amazing question. I love that you asked that. So while I was sitting here waiting for the talk to start, they just literally today made an announcement that Epic is now integrating some of these things like today. So you have Epic. So many of the things we talked about today are now going to be part of Epic. This is a very changing thing, but what I will tell you is that in January, ChatGPT announced that there will be ChatGPT Health. And then Anthropic announced there's going to be Claude Health. And then today, Epic announced that they are going to build all this and make it available right into Epic. So my point is there's a lot of different companies that are making these different tools. They are all trying to essentially compete for us to use them as part of our care. So Epic wants you to use their tool as opposed to going to some other company, for example. I want you to know the evidence, which is what I showed you today, and pick the thing that's going to lead to the best patient care outcome. So we have a lot of tools, many of them. Some are equally good, some are better than others. This is rapidly evolving. Just in the last few weeks, all of these things are starting to become more available. So it's going to be part of every moment of every day. It's just you're going to be using these new tools. You're going to be using them on the floor. You're going to be using them in the clinic. And they're extremely powerful. But the important thing is to know how to use them well and what the data is. And so that's the purpose of me kind of showing. I'm not giving you my opinion. I'm showing you the evidence and letting you decide what you want to do. And hopefully you'll pick the things that perform the best and have the best outcome for patients. So that was such a good question. It's so amazing that you asked that because this just was announced like an hour ago or something. So thank you.
Yes, but it's not going to be available until until hospital or.
Well, yeah. So each hospital is going to have to decide what it's going to do. So to give you some perspective on that, and this for anyone in the audience, you might want to think of this as a career path, is almost every hospital will have something called, it's a physician, an MD, that's title is Chief AI Officer. And the large academic centers all have it already. I don't know when we will have something like that here, but if you look at any of the really large academic centers anywhere in this country, there's a chief AI, there's several hundred chief AI officers, one for every medical school that has a massive medical center has a chief AI officer. And that's an MD like myself who's very knowledgeable about AI, who is involved with what gets deployed in Epic, how things get used for patient care, what gets done in the radiology department. So there is a role for physician leadership in this area. And just throwing that out there, if this is interesting for you and you want to make this part of your career path, there's a need for physicians to be guiding how this is being done in a safe way for patients. So great questions. I love your questions. They're amazing. You have anything else you want to throw out?
Also those predictive studies, so they were done with like in retrospectively, or is it like, how do you know that somebody's like going to have a flare up without like getting to it? So how do you know?
Yes, I will explain how that's done. So what you do is you have a data on thousands of patients. I showed you one where it was 4,400 patients. So that already happened in the past. So you have the data on those patients. So you train the model to see how that progressed. Now you give it an unknown. It's already been trained, so it can predict with almost 100% certainty on this unknown where nothing has happened yet. Based on this panel of patients of the past, it will now know for sure what will happen, almost for sure, 99%, if you give it a new unknown. So you train on old data, and then when you give it an unknown, it analyzes based on the patterns what would happen to this unknown. And you follow that unknown, and then you then determine, well, was it right? And it was right. All the trials that I show you now in 2026 is right 99 to over 99%. It's not 90, it's generally over 99. It's like 0.95, 0.99 for an unknown. But you first have to train the model. So there has to be training on known data from retrospective. And then when you give it an unknown, where these studies are measuring, well, was it right on the unknown?
So very excited, but right now we're just going into the treating something like prediction before it happens. Is it something that we want to do? Is it gonna be covered? It's just I don't know.
Right. So the hope is that as medicine progresses, we end up doing randomized, double-blind, evidence-based trials on these things. That'll be the next step. So when you and I see that, then you'd be like, I'm all in. But probably you won't be all in until you see that part. But this is just the very beginning of all of this in rheumatology. It's like truly the beginning. So it takes years to do these trials and so forth.
No, AI goes very quickly.
AI is going very quickly. Yes, I agree. Great questions. Wonderful dialogue. Anyone else want to fire out a thought? Doesn't have to be a question. It just could be a comment, a statement. Great. Well, thanks. Yeah.
I have one more last one.
Yes.
So basically, if whoever, any doctor, any provider wants to have access, they're gonna be able to have an access. And if we have an access, so the insurance companies and other entities will have access to everything too. They will be able to run, for example, somebody's applying for the life insurance or something. They can run the data and just make the premium based on it.
Yeah, so you bring up good points. So let me break it down into two parts. The first part has to do with, will we all have the same access? And the answer is no. Each hospital or health system has to purchase the AI access from whoever is providing it. And let's just talk about the one that was adopted last year, almost by the majority of the US, which is called ambient scribing. So you go into the office, you talk to the patient, you type nothing into the computer, it listens to the conversation, it makes the whole EMR note. The majority of the US, that was adopted. However, there's competing companies. So some hospitals have Abridge is their one. Some have DAX Copilot. There's all these, Rush has some other brand. So we aren't all using the same tool. It's like if you went to the gas, you need gas for your car, and there's a Mobil, and there's a Shell, and you decide so the hospitals are going to have to pick, who they're going to work with and have a arrangement. So what you have access to will depend on the hospital you're working at, So your second question was about insurance companies. So insurance companies started using it before we are. I know you've heard about that in the press. So I guess the way I think about it is the way you can help your patient is have the AI do the prior authorization letter and get everything approved, and it'll do it better than we can, and faster, so that you get things done. So they're going to use it on their end, but if they use it on their end and we don't use it, then that's not good for the patient. So we have to feel comfortable that we're going to start using it to advocate on behalf of our patients. So there's the administrative part, which is note writing, insurance, authorizations, and then there's the part I'm teaching about, which is how do you diagnose or treat a disease. So. Great. All right. Thanks for listening, and have a great rest of your day, guys. If anyone wants to do any research in this area, let me know. You can come up and we can get you started on a project.
Hey everybody, John here. Thanks for listening to another episode. If you enjoyed what you heard here today, please check out our website at www.americancollegeaim.org. Sign up to become a member. Also, save the dates, October 9th and October 10th, 2026. We'll be back live in Chicago, Illinois at the McCormick Place Convention Center for our second annual live scientific session. Sign up at the website to attend. Until then, we'll see you all on the next Melvin Monday. Thanks for stopping by. See ya.